Today, I would like to talk about autosomal recessive polycystic kidney disease, ARPKD. Statistical information is obtained from ARPKD CHF Alliance, PKD Foundation, National Kidney Foundation, National Institutes of Health, and Harvard Medical School. Other names for ARPKD are infantile polycystic kidney disease and polycystic kidney and hepatic disease type 1. Autosomal recessive polycystic kidney disease, ARPKD, is a genetically inherited disease in which clusters of fluid-filled sacs, cysts, form in the kidneys, often leading to kidney failure by the age of 1 and a reduced lifespan. About 50% to 60% of infants with ARPKD, like my sister, die within hours or days after birth due to breathing difficulties. The ARPKD incidence rate in the U.S. is 1 in 20,000 births. It is reported that the incidence rate in Asia is as low as 1 in 40,000 births. This gives an incidence probability between 0.005% and 0.0025%. It is reported that there are 14,000 people in the U.S. with varying levels of ARPKD and an estimated 12.5 million people worldwide. Assuming a population of 303.9 million as per the U.S. Census in 2012, then the incidence rate within the USA is 14,000 divided by 313,900,000, or 0.0045%, which is close to the reported birth incidence rate. The probability of a person being a carrier of this genetic disease is about 1 in 70, or 1.429%. Note that being a carrier does not mean that one is affected with ARPKD, just that one carries the genetic marker within chromosome number 6. Should one carrier meet another carrier and they both decide to have a child, then the probability of the child being affected with ARPKD, like me, is 1 in 4, or 25%. The child may be neither affected with ARPKD nor a carrier, like my young brother, and that probability is also 1 in 4, or 25%. Alternatively, the child may be born a carrier and lead a perfectly normal life without being affected, and that probability is 2 in 4, or 50%. For two parents who are carriers to meet, marry, and have children, that probability is 1.429% times 1.429%, or 0.0204%, meaning one married couple in about 5,000 couples. Even then, remember that the incidence probability among birth is 25%. Therefore, 1 divided by 5,000 times 0.25 equals 0.005%. The main concern with ARPKD is infants not being able to breathe because non-functioning kidneys in utero do not promote adequate lung development, like in my sister, who needed a high degree of ventilator support to supply oxygen and passed away after the first day. The majority of infants with ARPKD show enlarged cyst-filled kidneys in utero or within the first days of life, like myself. These cysts impair the kidney's ability to filter waste from the body. About 50% of infants with the disease will also have liver disease and enlarged spleens, like myself. These anomalies are often detectable through ultrasound before the child is born. Of the about 50% of infants who survive their first hours and days of life, about half survive till 1 year old. More than half of those children will develop end-stage kidney failure by the age of 5. In statistical language, the first detection of chronic renal failure has a mean observation age of 5 years old. Without dialysis or transplantation, the disease is often fatal. However, a small minority of children with ARPKD do not show symptoms of the disease until later in childhood, like in the teen years or early in adulthood, with liver disease being the dominant symptom. In these people, the kidney disease is often mild and liver failure is the primary issue. If faced with kidney failure, people with ARPKD frequently undergo dialysis, a cleansing of the blood through a machine that removes waste, or kidney transplants. If the liver is extremely damaged, a liver transplant may also be needed. Some people with ARPKD must undergo dialysis and or a kidney transplant while they are still in infancy. I had both of my enlarged cystic kidneys removed within the first 4 weeks. I was on dialysis for the first 10 months of my life, and I underwent a kidney transplant of my mother's right kidney. Of all infants who survived their first year of life, 86% survived to 5 years old, 71% survived to age 10, 63% survived to age 15, and 42% survived to age 20. Therefore, the probability of surviving till 20 years old is 0.5 times 0.5 times 0.42 equals 10.5%. 50% chance of surviving first hours times 50% chance of surviving past 1 year old times 42% chance of living till 20 years old. As per Massachusetts General Hospital / Harvard Medical School, for kidney transplantation, the current overall survival rate at 10 years post-transplant is 67%. For a living donor transplant, which is the type of transplant I had, the survival rate at 1 year post-transplant is 98%, 10 years at 87%. The 50% mean survival period is 15.06 years. For a cadaver transplant, the survival rate after 1 year is 89%, and the survival rate after 10 years is 47%. The 50% mean survival time is 7.3 years. This is the data today. When I had my kidney transplant in 1996, transplantation in infants was highly experimental, and the physicians told my parents that it would be unlikely for my transplanted kidney to last beyond 3 years, and for me to live past 5 years old. They said the same thing about me living to my teens when I was 5 years old. I am 18 years old now and have beaten the statistical odds several times. There is no doubt that my survival probabilities improved considerably from my parents' active medical intervention by undertaking what no other family had undertaken before at that time. I would not be here today if it were not for the experimental procedures that my parents agreed to undertake while I was in utero and also as an infant. These include reverse amniotic fluid infusions using saline solutions, which the vast majority of physicians insisted would not work. Thanks to the experimental procedures that were undertaken with me, many other children have benefited and have greatly improved their survival probabilities.